Thanks, Matt. Thanks for asking me to do this. And I believe for the trainees, this is going to be part of your sign-off as well. So it'll hopefully tick a few boxes for you. So common complications post-cardiac surgery, you could have a myriad of complications, and they're quite a bit of it that, will actually be useful for a presentation all of their own as well. Things like pacing and inotropes and vasopressors that we use. You could actually do a full presentation, a talk on those things themselves. So I'll try to keep it reasonably simple and straightforward. If I can, yeah, so there we go. So you could either have, as with everything else, you can have early or late complications, and usually the early complications that we have post-cardiac surgery is related to surgery. And they're also related to the comorbidities that the patient would come in with. So if you think about it, most of our patients are elderly with multiple comorbidities. They'll have, they'd probably be on antiplatelets and anticoagulants preoperatively. And they could have, because of lifestyles and everything else, they could be smokers, diabetic, hypertension. So it could all be related to, quite a bit of it is related to the comorbidities that they're present with. So just jumping right into it, the commonest thing that we see post-cardiac surgery is bleeding. And that's one of the reasons why when the patients come out to us, we wait for a couple of hours before we start to wake them up to just establish that they're not bleeding into the drains, and just to make sure that they're not going to return to theatre. So the reasons why cardiac surgical patients would bleed as much as they do is, one is the nature of the surgery. The surgeon is operating on vascular structures, so you could have bleeding points coming off, say, on the vascular conduit, so be they arterial, such as the lemur or the reamer, or venous grafts, so where they take off if there are any branches that haven't been tied off correctly, accurately at the time of grafting. So those bits can bleed. The patients could bleed where the wires would have gone through the sternum. They could bleed from the periosteum. They could bleed from the substernal fat, or they could have some pleural bleeds. So there are multiple reasons why they could bleed from a surgical point of view, but the other big reason why they could bleed is because they're in a cardiopulmonary bypass machine. So there would be hemodilution, there'd be dilution of clotting factors, of platelets. They could have pre-existing, medications with either anticoagulants such as warfarin or DOACs, or antiplatelet drugs. So all of that could contribute to the bleeding. Also, if and again, you've got to remember that they're going to be heparinized on the bypass machine. So if the heparin hasn't been adequately reversed at the end of the procedure with protamine, then that could cause bleeding as well. Or if the team decide to use cell salvaged blood at the end of the procedure, there could be residual heparin that might not be fully reversed with protamine. And sometimes you'll see patients coming from theatres with a bag of cell-saved blood hanging from the end of the bed. So obviously that blood will need to be reversed as well. So when you see that, then it would be reasonable to assume that the patient will need a dose of protamine. Normally here, we would give about 50 milligrams of additional protamine per bag of cell salvage blood that comes through. So there are multiple reasons why a patient would bleed when they come onto the unit. The other reasons could be if the patient is really sick, and we've seen that in the last couple of years through COVID, where with delayed cardiac surgery, patients are sat in hospital beds waiting for the surgery. So they might be on heparin, prophylaxis for DVTs and things like that. Or if they've had heparin infusion, usually get this with unfractionated heparin. So they might have immunological response to heparin, so you'll need to test them for HIT. So that might be the other reason why they might, respond adversely to heparin. So multiple reasons why they would bleed at the end of surgery. So the two main scenarios that you'll see when the patients come into the unit. One is a massive blood loss. You could have 400-500 mils of blood in your chest drains as the patient is being wheeled into theatre. So you could very safely say the patient needs to go back to theatre to have that blood loss addressed. Or there could be a grumbling loss, say less than 100 mils per hour that you need to keep an eye on, that you don't feel comfortable with, waking the patient up. So you could have a slow and steady bleed, or you could have a massive blood loss. So usually if somebody comes in with, that kind of loss in the drains, it is safe to say it's a surgical bleed. Sometimes, quite often, you have the middle ground where you have about 200-300 mils of blood loss, say over 3-4 hours. So you would need to keep a closer eye on them, and you would have sent all the bloods off anyway for testing, i.e., for coagulation and platelets and all that sort of a thing. You could do a TEG in that time to establish if there is a coagulation defect, or you could still have a surgical bleed in that situation. You could also have a coagulation defect with a normal TEG, and we see that quite often as well. So you would be you'll be monitoring the drain output. You'd be looking at the drains as well, because sometimes you'll see clots sitting in the drains, and therefore the blood loss is actually not very visible. And if that is the case, then you could miss a massive bleed. Occasionally, surgeons usually, if they've opened the pleura, they will put a drain into the pleura. Occasionally, they might not put a drain into the pleura despite having opened the pleura, and then you could have an occult blood loss in the pleural spaces. So if the patient, again, if the patient is unstable, they've come out of theatre and there is no theatre space, then we have opened patients up on the ICU. And we now have a protocol for opening these patients up on ICU. So most of the nurses on the unit are CALS trained, that is cardiac ALS, they're CALS trained, and most of our junior doctors who are there, or long-term junior doctors who are there, would, we would expect them to be CALS trained as well. So, there's a protocol in terms of how you open it up, and so we would get the patient ready to open their chest and ask the surgical team to come ASAP to the ICU, and we do open chest on the unit. So again, as I said, you could have variable low level of bleeding, and we need to monitor them, both with the blood loss, hemodynamics, as well as blood results from the lab. And you could have situations where a surgical blood loss, surgical bleed, can lead to coagulation defect, and a coagulation defect can lead to a surgical blood loss as well. So you could have both situations in the same patient. Okay. Again, as I said, you check all of that, and you check the calcium as well, because again, a lot of our patients could come out with low calcium levels. I've described why they would have clotting factor deficiency, because it could either be hemodilution on the cardiopulmonary bypass in the prime fluid, and there could be a defect from pre-existing drugs such as warfarin. So they could be vitamin K factor associated deficiencies. So fibrinogen, heparin, platelet function, any of those things could give you, what the surgical surgeons would like to call it as an anesthetic bleed. Okay. So if you do, for those of you who are trainees and doing your cardiothoracic block right now, so if you see this, then definitely escalate it upwards to the ICU consultant, and then we can get the surgeons to come in. to have a look and make a decision whether the patient needs to go back to theatre or not. And again, tranexamic, most of our patients would have had a tranexamic infusion in theatres. That's the primary antifibrinolytic agent that we would use in this hospital. And you might need to top them up in terms of platelets, coagulation factors, and all of that. Okay. You might have normal TEG. You might have normal bloods, but the patient is still bleeding. And if in doubt, the safest thing really is to take them back to theatre. Because as I've said already, a coagulation defect can exacerbate a surgical bleed, and surgical bleeding can exacerbate a coagulation defect, because if you have massive blood loss, you can have a coagulation defect as well. Okay. So when they go back to theatre, quite often they'll come back and, the surgeon will look at you to say, what a waste of time, because there wasn't a bleeding point in there. But quite often, more often than not, we see that when they go to theatre and have had that blood clot, which is sitting in the heart, around the heart, cleared out, actually the bleeding stops when they come back to us. So they might not find a bleeding point, but a return theatre often seems to correct the blood loss. Okay. So going on to the next, complication that we get quite worried about is pericardial tamponade. Now, as I mentioned earlier in the bleeding part of the talk, sometimes you'd see clots sitting in the drains, and when the clot is sitting in the drains and then the drains are blocked, then you can have a pericardial collection, and that pericardial collection itself can compress the heart. So you might think, they came out with 200 mils blood loss in the first hour, and after that it has actually stopped. So that might be because the drains are clotted off and the patient is bleeding internally, and you have no idea that, and you think that the blood loss involved. So when is it a tamponade? The definition for tamponade is when the pressure within the pericardium is equal or exceeds the pressure in the atrium and the ventricles. So that's when you have a tamponade, and you can easily demonstrate it on echo. So if you were to do an echo, you will see the clot in the pericardium compressing the atrium and the ventricles. Okay. So so as I said here, it is because there's bleeding into the closed pericardial space, because the pericardium is always closed during surgery. After surgery, the pericardium is always closed. Okay. And again, we've spoken about blocked drains. Okay. So tamponade really would be, depends on the rate of accumulation. So if it's slow, it could collect. If it's a slow bleed, the drains are blocked, it could collect over a number of hours, and sometimes the patient will present, say, middle of the night, with a typical clinical cross picture of tamponade. Or otherwise, you could have an absolute volume loss, an absolutely big bleed into the pericardium that is compressing the right atrium and the ventricles. So if it is a large volume over a gradual period of of time, the patient might actually tolerate that. So they might have that big loss, and you might actually tolerate it, or they might not. But small volumes, might also cause a collapse. So you need to be aware of these things. Okay. So we've spoken about this when pericardial blood pressure equals or exceeds the pressure in the atria and ventricles. Anybody want to tell me the clinical signs of a tamponade? Anybody?
Hypotension.
Yeah, hypotension.
Extending neck veins.
Yeah. Extending neck veins, yes, but then you're not going to be seeing it in a patient who's got a central line, really, isn't it? So what would you see in that thing? High CVP, yes. Anything else?
The Soltimans and the ECG.
Yeah. So low blood pressure, high CVP. Anything else? Tachycardias, yes, unexplained tachycardia. But again, you're looking at cardiac surgical patients, so they could be tachycardic, or you might have paced them at a higher rate as well. Anything else?
Cardiac arrest.
Cardiac arrest, eventually, in untreated situation, a cardiac arrest, yes. What about urine output and, end organ? Exactly. So you could get hyperperfusion of the kidneys, so reducing urine output, metabolic acidosis, lactatemia, all of those sort of things. Okay, so gradually reducing blood pressure, increasing CVP, increasing heart rate, decreasing urine output, increasing lactate, and change of a cardiac shadow on the chest X-ray. If you were to do a chest X-ray, normally, in the past we used to do routine chest X-rays on all our patients who come out of theatre, but we don't do that now because we've found that a routine chest X-ray doesn't really change very much in our post-operative care, so we don't do that routinely. But if you were to do a chest X-ray, you will see a change in the heart shadow on the chest X-ray. But the most useful one really is cardiovascular collapse and arrest, is an echo. So if you were to do an echo, you will actually see the blood clot in the pericardium compressing the atria and therefore reducing inflow into the right ventricle, and in extreme circumstances you'll also see pressure on the right ventricle as well. So you'll see a complete collapsed right atrium and a right ventricle. Okay. So as I said, it is confirmed by echo. Okay. Again, as we've said earlier, a collection doesn't equate to a tamponade. It equates to a tamponade when the pressure in the pericardium exceeds the pressure on the atrium and the ventricles, and therefore causes a reduction in forward flow and low cardiac output. Okay, so usually it is surgical re-exploration. So on occasion we have opened the patient up on the unit, as we've said earlier on, for bleeding. It seems to be less these days, with bleeding is much less if they've had off-pump surgery, because you've taken away the risk of being on the cardiopulmonary bypass circuit, but also improved in surgical techniques and taking care of patients' temperature. So that's the reason we warm them up before you wake them up, because hypothermia can also cause coagulation defects. So it is rarer these days for us to actually open a chest on the unit, but when it occurs, we do have to open it up on the chest, or on the unit. Okay. Any questions on tamponade? Okay. Yes.
Sometimes it can be a cause of a brain.
Yes.
So
what you can do is we do milk the drains. So that there is a clamp that's got sort of a roller blades on it. So you can actually milk the drain. So if you see that there is a clot sitting there, you can milk it to get rid of the clots. Okay. The nurses will do it. The surgeons will come around and do it. So it's not an issue. Okay. In fact, we are quite gentle when we milk those drains. The surgeons will come and put a bit of elbow grease into it. Okay. So diuresis. Now, it's actually quite common after cardiac surgery, and often the reason for that is they use mannitol in the prime fluid, and because of that you might end up with a patient who comes out with 400-500 mils of urine output in an hour. I mean, I think last week when I was on call, I think in the first hour the patient lost about 400 mils of urine, and in those 2 hours it was almost a liter and a half of urine output. So you do need to keep up to speed with the volume that is coming out. And also we are not very good, particularly on this in this hospital, with actually looking at the fluids in and the fluids out on the perfusion charts. The perfusionists don't really tally the fluids up for us. So we're not really very good at looking at the fluid balance in theatres. So when they come out, we sort of start at 0. So the patient might actually have been quite negative even in theatres before they come to us. So we do need to keep an eye on that and give them volume as appropriate. But also remember that this is cardiac surgery, so it's a highly stressful surgery. So they would be secreting ADH quite significant quantities. So they actually would be, in normal circumstances, if it wasn't for the mannitol, they might actually be oliguric, they might be retaining volume. So because you've given them mannitol there and they are having, polyuria, they might actually be quite negative. So you need to keep, think about that when you are giving them fluids post-operatively, because again, surgeons worry about us giving them too much fluids because they think that the myocardium is stunned and therefore they would want us to restrict the amount of fluids we give them. But you do need to look at the patient's physiology when you're prescribing the fluids for them. Okay. So it can lead to negative balance. It can lead to hypertension, metabolic acidosis, and lactatemia as well. So without, the nurse at the bedside might increase the inotrope or the vasopressor, administration without actually giving them the fluids that they require. So you do need to keep an eye on that. Okay. So again, this polyuria can lead to depletion of electrolytes, and in cardiac patients in particular, you need to be really careful about the potassium levels and the magnesium levels, because that can lead to arrhythmias later on. So generally in cardiac, we tend to keep the potassium levels around 4.5 to 5, and magnesium levels also more than 0.8 to 1 millimoles, because normally you tend to aim for 0.8 millimoles, so we tend to keep it at a higher levels. Okay. And also, the polyuria is not really because the kidneys are functioning really very well. It could be the polyuria may mask kidney function. Okay, so you need to be aware of that. The next thing is vasoplegia. So they come out with varying degrees of vasoplegia, and that is because, again, there's a stress response to surgery, but also because they would have been on a cardiopulmonary bypass circuit. So that in itself can create an inflammatory response in the patient. You can get quite a vasoplegic patient. And there was on occasion, the vasoplegia can be so significant that you think that they're having an anaphylaxis, because nothing that you do actually seems to be able to correct that vasoplegia. So it can mimic anaphylaxis. It does depend upon the length of the patient being on cardiopulmonary bypass, the hypothermic levels that they would have got the patient down to while they're in surgery. It could also mean, skip through. It could also be because of the antihypertensives that they might have been preoperatively, so ACE inhibitors, angiotensin renin, blockers, calcium channel blockers, alpha blockers. So all of that can cause vasoplegia. So it is quite important for you to be aware of that as well. So again, as we know, there's a persistent drop in blood pressure, there is hypertension, there's lactatemia and metabolic acidosis. They can mimic anaphylaxis and sepsis. Okay. So what do you do with it? You monitor them. We tend to use pulmonary artery catheters, flotation catheters quite frequently on this unit. So if what you're doing normally is not addressing the issue, if you've given them enough volume, if you've given them enough vasopressors, and you've gone on, and again, it's quite common for cardiac surgical patients to be on a couple of inotropes and a vasopressor, and if the amount that you're giving is going up, then it is important that you put in a monitor in to see. So we would do an echo quite early on to see if there is an issue with contractility or an issue with filling, and then maybe even put a PA catheter as well. So you would need to, as I've said there, you'd need to confirm the contractility, you need to confirm the volume, and then you might need to add in noradrenaline or vasopressors. On occasion, we also add in septic doses of steroids as well. Okay. And remember that, you know, as you treat, your lactate might go up because you're actually treating the vasoplegia, because with improved perfusion, the lactate might go up as and then drop with time. Okay. So again, as you know, everything that we've just discussed, remember that blood pressure is a product of your, is a function, not a product, but a function of your heart rate, circulating volume, peripheral vascular resistance, and contractility. Okay. And you need to, which is why we do an echo to see what the heart is doing. We also look at the rate and rhythm. So most of these patients, because the myocardium is stunned, we tend to have them at a higher rate than they might have been used to preoperatively as well, because cardiac output is a function of your rate and your volume, particularly in our cardiac surgical patients. So make sure that the rhythm is that the rate is important, and also make sure that they have the atrial contribution to the ventricular contraction as well. Okay. So MIs, they're quite uncommon after cardiac surgery because the patient would have come in for MI most commonly. So it is quite uncommon, sorry. But it can happen, and the reason it can happen is anybody? Sorry? Yeah, so graft failure. Yeah. And why might you get a graft failure?
Surgical technique.
Surgical technique, yes. Yeah. So the graft, because again, these are venous grafts and they can be quite long, so they can kink. They can kink, you know, where they've been grafted. Inadequate or improper de-aeration after when they're coming off bypass. So that in itself can cause, you know, air bubbles to go into the vessels, and that can give you an MI post-operatively. Or if they're doing, say, a mitral valve surgery, they could have blocked off one of the coronary ostia, so that could cause an MI. So, as I said, it is, as always with MIs, there's a mismatch between delivery and demand. Inadequate cardioplegia, blocked, kinked, or dehisced graft as well. Blocked coronary ostia, especially when they're doing a mitral valve surgery. Disrupted coronary artery grafts. And then for us on ICU, the most important thing is if we haven't prescribed antiplatelet drugs post-operatively, which is why those of you, James, you've been here for a little while, which is why we are quite particular about aspirin, post-operative aspirin. So they do need to get post-operative aspirin if the surgeon is happy with it, we actually give them aspirin on the day of surgery. So if they're still intubated, we give 300 milligrams of aspirin PR 6 hours after surgery. If they're awake, we can give it as an oral dose. So we're quite particular about restarting antiplatelet drugs. Also, you know, things like clopidogrel or prasugrel, if the surgeon wants them for the next day, we restart them the next day. Okay, and to address the delivery and demand issue, we do start them on a small dose of bisoprolol as well for the next day. So we start them as 1.25 milligrams or 2.5 milligrams the next day. Okay. And again, how do you diagnose this? It's actually quite difficult to diagnose this biochemically, because what is high troponin in somebody who's had post-cardiac surgery. You will, even in normal circumstances, you'll have troponin levels of about 4,000-5,000 in post-operatively, and that is quite common. So when we have had situations where patients has had an MI, the trop levels that we see is somewhere in the 50,000, 40,000, 30,000, 50,000 sort of a thing. So that really is a good and proper unequivocal MI. So you'd either need to take them to cath labs to have a look at it, or they need to go back to theatres. So post-op instability, you do need to think about an MI. Okay. You could have ECG changes. Yes, you will have some ECG changes on that. So yeah. The ECG changes though, sometimes you get a pericarditis type of a subtle shape ST depression, but that could actually be normal because of where the surgery has happened and pericardial handling and things like that. So you could get pericarditis type of ST. Okay, so again, this is normal stuff. Arrhythmias, definitely have a think about an MI. Somebody who is cardiovascularly unstable, who seems to have low cardiac output, cardiogenic shock, those sort of situation, definitely. Failure, okay, and cardiac arrest. Okay. Clinical suspicion, so you do need to have a low threshold for suspecting post-op MIs. Again, on this unit, we do echoes quite frequently, so any regional wall motion abnormalities or changes from the previous ones. ECGs, again, changes from the previous ones you would do. And if you do suspect, then talk to the surgeons. We might need to take them to a cath lab. So before we extubate them, we might make a trip to cath lab, confirm for ourselves that this isn't an MI, and then come back to the unit, or confirm for ourselves that this is indeed an MI, and they go to theatres, okay, for a reopening and relook. Okay. So again, this is box standard stuff. So if you decided that they're not going to theatres, there's not much that cardiologists can do. It is box standard heparin, GTN, inotropes, and then the mechanical support that we would institute in these patients would be an aortic balloon pump to reperfuse, to increase coronary perfusion, or ask Matt if you would consider a VA ECMO for these patients. Okay. Shaking his head. Okay. So again, as I said, PCR, you might want to do an angioplasty or a stent, redo grafts, or if it isn't grafts, but say an MVR, you would want to do a new graft. Okay. So again, we've just spoken about pericarditis. So it is quite common. You will see saddle-shaped STs on ECGs. It's could either be because of the inflammatory process, or it could be because of surgery, surgical handling. It's insignificant. We tend not to worry about that, and it usually passes off with no sequelae. Okay. So respiratory complications are quite common for our patients. Again, it could be because of their comorbidities, the pre-existing baseline, that they could have pre-existing pathology, i.e. COPD, have restrictive lung disease, or any of those sort of things. So you could have a pre-existing problem, or it could be because of inadequate, because the lungs are, they do stop the lungs while the patient is on a bypass machine, so inadequate expansion postoperatively, or collections, pleural collections, or the patient's body habitus, large patients unable to take deep breaths, diaphragmatic splinting, all of that. So we do need to aim for the patient's normal rather than what we think is normal. So not going to be aiming for PaO2s of about 13. Okay. As I said, atelectasis. And again, most of these patients are put onto a water circuit before they're brought across to the ITU. And while you're changing from theatre circuits to the water circuit during the transfer, and then again from the water circuits, putting them onto the ICU ventilator, there's de-recruitment as well. So some patients do need to be bagged, but I would be very careful about your bagging as well, because sometimes an over-enthusiastic bagging of the patient when they come to the unit might actually cause pressure on your grafts, especially venous grafts. So you do need to be careful when you're bagging the patient up. Okay. Secretions, ET position. Again, we don't do post-op chest x-rays as often as we don't do them routinely. So it does depend on clinical suspicion. So if the patient is hypoxic and hypocarbic, check that the tube is well positioned. Pain could be an issue. So most of our patients, when they come through from theatres, would have received about 10 milligrams of morphine before they're brought across to the unit. But that quite often, especially for the younger patients, larger patients, is not enough, and they might need additional pain relief when they come up to the unit. Now, intracardiac shunt is rare, but can present. We have had instances where the patients have had an opened PFO post surgery, and that can cause a persistent hypoxia and unexplained hypoxia. So unless that was picked up on TAE intraoperatively, or even if it is picked up intraoperatively but not commented on, because you're really not going to be closing all the PFOs that you see intraoperatively, it might take you by surprise. So we have had a couple of instances over the years where there was an undiagnosed PFO and we were wondering why the patient is still hypoxic. And then you finally diagnose the PFO, they then go to cath lab and have that closed percutaneously, and you're able to wake them up and extubate them as soon as they come back from the cath lab. Okay, so intracardiac shunts are rare, but when they do occur, they can, demonstrate their presence quite dramatically. Okay. Pulmonary hypertension could happen, especially if you've got patients who've got chronic respiratory disease. That can give you the pulmonary hypertension, or if you've got them with valvular disease like mitral disease, they can present with pulmonary hypertension, and that can give you the hypoxia. Okay. Any questions? So the other thing that we need to be wary about and consider is ventilator-associated pneumonia. So if you're not able to extubate them, then they are at risk of hospital or ventilator-associated pneumonia. So you need to be aware of that and treat that accordingly. PEs are uncommon because most, we've spoken about patients bleeding when they first come in, but they can present with a PE if, further down the line, as a late complications. Acute lung injury is also uncommon, but you can have lung injury associated with cardiopulmonary bypass, massive transfusion, positive pressure ventilation, all of that, if you're not ventilating them in accordance with ARDS principles, then lung protective principles, then you could have that. Amiodarone, we use amiodarone like water on this unit. It's not that common, especially not in the acute phase. You could have high CO2, again because of secretions, opiates post GA. So the patient could be quite drowsy, so they could be quite elderly and frail and you've given them too much opiates, so through the night they might build up on their CO2. Again, late could be critical illness neuropathy, cerebrovascular disease, ARDS, all the usual stuff. Okay. As I've said, you could re-recruit the lung, but always be careful about how you re-recruit because you could occlude the grafts. But also, when you're recruiting, be aware of the impact of large tidal volumes can have on venous return and hence cardiac output. So be aware of that. Okay. You could, if there's retained secretions, if the nurse tells you that they're struggling to get the secretions up, then tracheal toilet, depending upon the cause, really. Yeah, all self-explanatory. Okay. Again, do an echo if you have any, if you have a hypoxic patient. So it might be that they've got a shunt, that they've got an intracardiac shunt, so do an echo to see. And also sometimes other thing that you can't pick up on echo is pleural collections. So if they've got a massive pleural collection, that because again the patient is supine, isn't it? So X-rays that you see might not pick up the pleural collection. It might just be a haziness on the chest X-ray that you're not going to really see. So echoes would also pick up pleural collections, lung collapse, lung consolidation, all that sort of a thing. So an echo would be useful. Again, extreme cases, you might want to add in nitric oxide if they've got pulmonary hypertension. You might want to, again, ask the kindly ECMO consultants if they would consider that. It's very, very rare. We've never ever asked them for that. No. So again, renal impairment, as I said, it's quite common. It is usually self-limiting. Possibly about a third of our patients would come in with would develop post-operative renal impairment. It could be related to preoperative chronic kidney disease. It could be transfusion related, coronary bypass. It could be hypertension post-operatively as a response to it could be as a response to the stress of the surgery as well. So it could be many things. So any one of those things could be could result in renal impairment. Generally, what do? We just observe them. We keep an eye on kidney function, urine output, and see if it plateaus out or if there's a downward trend. In about 2-3 days, we discharge them to the ward. Very, very rarely do we need to use renal replacement therapy. And the reason why you might want to use renal replacement therapy would be the usual stuff, such as metabolic acidosis or electrolyte imbalances. Rarely fluid balance as well. So sometimes, the patient has been with us for say 2-3 weeks and they are quite edematous. They were struggling with the hypoxia, and it is quite apparent that they're fluid overloaded. So we might use it as a tool to take some fluid off. Okay. Again, I think we've discussed all of that really, isn't it? So these are the associated things that you would see with renal impairment. So if you have renal impairment and the patient is likely to have multi-organ dysfunction, and that would be associated with neurocognitive dysfunction, pericardial collections, platelet dysfunctions, all of that, and that is associated with increased mortality. Okay. Again, as I've said, depends on severity. We do avoid nephrotoxins. It's very, very rare for us to use So much so to say that we never use non-steroidals on the unit for pain relief. So we avoid nephrotoxins. But again, you know, furosemide could be classed as a nephrotoxin. So we use a shed load of furosemide. We use antibiotics, which could be nephrotoxins. But you know, as far as non-steroidals go, we very, very rarely use non-steroidals. Again, first principles, maintain perfusion pressures and circulating volumes to avoid acute kidney injury. It does, we do tend to use renal replacement therapy in about 5 to 10% of patients, but not more than that. Okay. It usually resolves. We very rarely, they very rarely need renal support post-cardiac surgery. They're very rare. Unless, of course, you know, they've had a transplanted kidney and that is failing, or they've been on dialysis before surgery. Okay. So on this unit, once we decide that we need to, that we're going to start dialysis, our policy is that the vas cap needs to go in within 2 hours. The nurses will get the machine ready within those 2 hours. So the aim is to get the patient onto renal replacement therapy within the 2 hours. Okay. So if you are struggling, what that means really for you is that if you are struggling with placing a vas cap, then escalate it upwards. Okay. Again, rhythm disorders goes with the territory. You can have transient rhythm disturbances, a lot of which could be related to electrolytes, either potassium or magnesium. It could be related to reperfusion, or it could be an ischemic myocardium. So, you know, patient having myocardial infarction or ischemia, that you could have arrhythmias related to that. Especially if you've got if the patient has had valve surgery, then you could have the reason could be mechanical disruption. So if it is a mechanical disruption, especially following an AVR or an MVR, then the treatment really would need to be permanent pacemaker afterwards. But then you don't normally, you know, refer them for a permanent pacemaker till, say, day 4 or 5, till we are sure that it isn't, you know, a biochemical reason or something temporary like edema around the fibers. So so those are the things. Very, very common is AF. So we see AF very, very commonly. Sometimes it is seen intraoperatively, and the patients might come out with amiodarone as they come through to the unit itself. It does increase the length of stay on the unit, especially if it is if the AF has an impact on blood pressure and they're needing management for that. So if they're still intubated, then it becomes easy for us to cardiovert them. But even if they're not intubated, you could cardiovert them. And this is the reason why we start them on bisoprolol on the day following day. The reason to avoid AF, especially post-grafts. Okay. So you can get a whole spectrum, AF being the commonest, but you can get a whole spectrum of dysarrhythmias, say from first to second to third degree heart block. And if they do get third degree heart block, we tend to keep them on the unit till we've got the pacing sorted, because it is quite risky to send them out to the ward. And sometimes they've got both atrial and ventricular asystole, so they definitely will need a pacemaker. Okay. So again, how would you manage them? You would do the routine stuff, such as check the electrolytes, check the calcium, potassium, magnesium, make sure all of that is sorted. Check that they're not in pain. Check that, you know, have a look at the inotropes and the vasopressors that are running. For instance, dopamine is quite arrhythmogenic, so you might want to start reducing or consider weaning the dopamine down, and you know, or even adrenaline, you might want to consider weaning those things down. You might want to consider starting them on, say, you know, phosphodiesterase inhibitors rather than using these as inotropes. So you would need to rationalize your inotropes. You might need to look at, as I said, correct the pain, correct acidosis, correct lactate. Ensure, the biggest issue really is to ensure that you're pacing correctly, that you're not having R on T phenomena. So if you were to pace them only with on you know, VVI, then you are at risk of pacing them doing R on T. So look at your AV delays. Look at whether you're having them on DDT or VVI or AI. So have a look at all of that. So that bit is important. So look at your pacing box. And then exclude mechanical problems such as, say, you know, are they having myocardial infarctions or ischemias because there is a blocked graph, or if there is a tamponade, say, are they having, is a tamponade presenting as an arrhythmia, as a tachycardia and an arrhythmia? Okay. So normally, as I said, we use amiodarone like water over here. So we would start them on amiodarone. The other things to consider would be digoxin, especially if they've got low cardiac output and you're trying to achieve rate control rather than rhythm control. So you might want to consider starting them on digoxin as well. But you'll need to keep an eye on it if renal function is a little bit iffy. Okay, so in situations where you know, they've got complete heart block or they're completely asystolic, you will need to get a cardiologist to review them, and they might need a pacemaker. I think that's about it for me. Any questions? Anybody from the Royal? So I did not want to talk about inotropes and vasopressors, as well as, you know, a detailed discussion on pacing in this talk, because it just becomes quite unwieldy. So that's that.
So, in regards to the bleeding complication and opening in the ITU,
yes.
If there is no space in the theater, let us say.
Yes.
So by whom does the surgeon who had the operation, he has to come, or?
No, it's not. So the on-call surgeon, you'd call the on-call surgeon, so you'd call the on-call surgical registrar, and they will call the on-call consultant to attend. If the on-call consultant feels that he'd rather not and refer it on to the surgeon who operated and the operating surgeon attends, that's fine. But that is their decision, that is their arrangement. Whereas from our point of view, we call the on-call team.
Okay, thank you.
And that goes for taking them back to theatre as well. Any other questions? Andy or Ravi? Because I don't think there is a journal club this week. Ravi?
When I was working in Glenfield, the one thing which used to confuse me was sort of the normal TEG in the face of a patient who was bleeding. It took me some time to understand that it can happen, and we will do it, but still we end up giving products even though the TEG is completely normal or appears because probably the patient must have received some products already, still bleeding.
Yes.
TEG, I didn't actually find it that useful.
I know it looks like voodoo, doesn't it?
Yeah.
You know, we've given them one round of products, we're giving them a second round of products in the face of a normal TEG, normal fibrinogen levels. But again, you know, it could be, we need to see whether having platelet function monitors would be better, service better than just a TEG that we have. But again, you know, a mild coagulation defect will exacerbate a surgical bleed, and a surgical bleed would exacerbate a mild coagulation defect, and the patient will continue to bleed. And also you would have seen, Ravi, that, you know, they go to theatres, the surgeon comes back and, you know, and says there wasn't a bleeding point, but once they've been to theatres and have that trip to theatres, they come back and they're dry.
Yes.
It does seem a little bit like the dark arts. I agree. Okay. I think if there's nothing else, thanks for attending, and see you all.
Great, thanks, Rajni.
Thank you.